The assessment of congenital heart disease can be challenging, but keep in mind the most common conditions are ventricular and atrial septal defects, followed by patent ductus arteriosus. All of these lesions cause a left-to-right shunt. Such congenital defects are associated with chromosomal abnormalities such as Down and Turner syndromes. Now examine the hands for clubbing and cyanosis. Look at the face for dysmorphic features and in the mouth for central cyanosis. Examine the neck for the jugular venous pressure. Pulmonary hypertension is an important clinical feature in patients with congenital heart disease. Look for the waveform of tricuspid regurgitation in the JVP with a prominent V wave and a steep Y descent. Apply moderate pressure on the abdomen to demonstrate hepatojugular reflux. Important findings in the chest include the presence of cardiac devices such as pacemakers, evidence of previous cardiac surgery, and displacement of the apex beat due to ventricular dilation. Assess for a palpable shunt or thrill in the third or fourth intercostal space. A right ventricular heave and palpable second heart sound are important signs of right ventricular failure and pulmonary hypertension. Ventricular septal defects produce a harsh, high-pitched, pansystolic murmur loudest at the left lower sternal border, sometimes with radiation to the back. The murmur is not usually affected by respiration and can be accentuated by hand grip. The smaller the defect, the louder the murmur due to high pressure shunt and more turbulent blood flow. The murmur can disappear with ventricular pressure equalization. Atrial septal defects do not usually cause a murmur, but classically cause a fixed split S2. This is best heard with a patient in a sitting or standing position. The murmur of a patent ductus arteriosus is continuous and harsh, often described as machinery-like. Best heard over the left upper sternal border and may obscure the S2. Tricuspid regurgitation is often present in patients with congenital heart disease due to pulmonary hypertension. Eisenmenger syndrome occurs when pulmonary pressures become higher than systemic pressures. The shunt direction changes from left to right to left, causing cyanosis. Tetralogy of Fallot, TOF, is a common cyanotic congenital heart disease, often repaired in infancy. The most common long-term cardiac problem for these patients is pulmonary regurgitation and right ventricular volume overload. Percuss the lung bases and auscultate the lungs. Ask the patient to lay on the bed. Palpate for hepatomegaly, pulsatile liver or ascites, features of right heart failure. Assess the lower limbs for edema, pulses, scars and clubbing. Differential limb clubbing and hypoxemia present in toes, yet absent in fingers, is seen in PDAs when the shunt is distal to the left subclavian artery. When summarizing your findings, consider underlying syndromes, whether defects have been corrected. Assess for complications including pulmonary hypertension, cyanosis, and endocarditis. Oh, look at him go! He must be feeling better. Okay, now don't overdo it. Okay, Gilbert, just slow down there.